Okay. So community information exchange, a tool for whole person care. Let's go to the next slide. And I just wanted to remind folks what this really is all about. And this vision of completion here is really very foundational to Healthier Here as an organization. Our efforts to help create a connected system of whole person care, strengthening the coordination of care for those in need by connecting people, service organizations, and community partners more quickly and more effectively, resulting in a more healthier, more equitable community for all. This is a vision that was developed by a number of partners in King County. This was when we were just getting this CIE work started a couple years ago. We brought a number of organizations together to try to de-silo some of the data silos that existed, the initiatives, the efforts, the funding streams that were supporting disconnected systems. And really, this is the vision that we came up with, is creating this coordinated system. And we really saw the community information exchange as being a tool, a technology tool to undergird the relationships, the referrals, that would make it possible for people in our community to receive integrated whole person care. So if you go to the next slide. So essentially, as I mentioned, this is really what community information exchange has been about, is about bridging the silos, really connecting clinical organizations and behavioral health entities to community-based providers and social service agencies, really being able to address people's whole person needs, not just clinical or behavioral health needs, but also connecting them to resources in the community that can help address some of their social determinant health needs. So some of the functions that this CIE would provide is a list of resources, a way to do closed loop referrals, and to share data appropriately about common clients and patients to be able to improve service to these individuals. Really also, as I mentioned, connecting existing networks where it made sense to create and provide a unified interoperable system, a system that is governed and managed by the community of providers in King County, and that is sustainable, that we are building something for the long term. So if we go to the next slide. So it's been a very busy year and 18 months plus. Healthier Here, together with more than 90 clinical and community partners, we have been involved in co-designing what we are calling the Connected Community Network in King County. So the Connected Community Network is a community information exchange that aims to strengthen care coordination in our region by connecting social service, community, tribal, and physical and behavioral health organizations in our region. So through our partnership with Crisis Connections, I think this is actually one of Allie's parting gifts to us before she moved over to Harborview, was working together with us and Washington Serves, which is a veterans serving organization. We applied for the Vet Seniors and Human Services levy dollars coming from King County government, and were awarded those dollars for our planning purposes over the next couple of years. We also worked together with Kaiser Permanente, as well as Community Health Plan of Washington, to help launch the Unitas technology, a closed loop referral platform in June in the King County region. And then we developed, in the latter half of this year, all virtual, all online, through our network of community partners, an implementation plan that was a part of the requirements to the county. And we are in the process of contracting some expertise in tribal data sovereignty to help us be able to expand the CIE to address tribal issues and indigenous issues around data sovereignty. And then you can see there, sorry, go back one, that's our new logo. This is a name that was developed by our network of partners, the Connected Community Network, with a logo. We're in the process of developing a website that will house all of the work of this group. So next slide. So as the slide says, I think some of the successes and obstacles that we have encountered, we have a really wonderful, strong and diverse network of partners involved in helping to co-design and plan the CIE for our region, despite COVID. In fact, a number of the organizations, I think, after COVID came to our region in the spring, a lot of things shut down. Healthy Here actually had to transition a number of activities to supporting our partners around their COVID response. But during that time, we also checked in with our partners in terms of, can you really still make the CIE work a priority, given all that you have going on? And I think the response back was really like, we are swamped, but gosh, if we had had a CIE in our region, it really would have helped us with our COVID response. And as a result of that, we have, since the summer, been going very strongly, all virtual, having regular meetings with our partners to really put this system into place to be able to support all of the myriad of needs in our region. So we also have, actually, I think there's now a few more than 20 partners, but there are a number of partners, 20 plus partners that have adopted this new closed loop referral system that was launched in June of 2020. And then, I think it's both the obstacle as well as the opportunity. I think people are very busy, especially now with the resurgence of COVID, with their COVID response, but also still willing to be engaged. And we're actually trying to figure out how we might be able to leverage this for more immediate support to partners that are responding to COVID through the CIE platform. Next slide. So some of the future risks, COVID. I think, again, because of the demands on providers, people are just bandwidth is just very limited. But I think for certain organizations, it is a priority. We have been really working hard to make this as low barrier for our partners and providers to engage with the CIE work and be involved. We are, as I mentioned, we had submitted an implementation plan to the county just last month that we are finalizing at the end of the year, and then we will go into full execution mode around the planning that we've been doing in 2021. So completion to date, over 20 organizations using the closed loop referral system now, and planning on an expanded number of services and organizations by the end of 2021. So we are going full board despite COVID, and are just very appreciative of all of you, your listening and your support for the CIE work. So thank you.
Thank you, Gina. One question that I've got would be, King County, we're talking about a lot of population there, but there's a lot of the state left. Has there been discussion about how to take it from King County to create a statewide model for this?
Yeah, so I would say, interestingly enough, so I mentioned the closed loop referral technology platform, which is the Unitas technology. That has been brought to our region through a rollout that Kaiser Permanente has been doing through its Thrive Local initiative. And it is also being rolled out in Pierce and Snohomish County, and also in the Spokane area. And as a result of that, that has actually really put us into a great position to have conversations with our sister ACHs, Yakima 2 as well. That's great. In our sister ACHs down in Pierce County, that's Elevate Health, as well as the North Sound Accountable Community of Health. I know that the Olympic Community of Health on the Olympic Peninsula is looking into this further, as well as I see Yakima as well as Spokane. So we are building some momentum. I think the state, Sue can probably speak to this better than me, I think is watching what is happening. I know that the Healthcare Authority has some of their own ideas for how to support this work. And so we have been regularly in communication and really looking to expand and share what we are learning by implementing here locally with the statewide vision.
Yeah, so there was a request made to use CARES Act funds to purchase this for the entire state so that we had uniformity. Unfortunately, I think Department of Health was pretty far down the path with some other IT systems that we're just going to have to force some interoperability on. But I do believe we'll see many of the plans and carriers come forward to urge the legislators to weigh in on this issue too. We haven't given up on making Unitas a statewide platform, but it's very likely that we're going to have to settle with two. I am, though, concerned because, for example, in the children's mental health group and whatnot, there's a number of initiatives with things like the universal developmental screening, and most of that is being hardwired off the other system and not necessarily connecting into the Unitas closed loop referral system. So believe me, we are in very significant discussions with our sister agencies, but we have not arrived at a statewide solution yet. But I think it's going to be important in this presentation to help Gina. By then, I think there'll be a little more, hopefully by October, there'll be a little more awareness about how we're going to create this interoperability piece.
And let me just mention that, you know, from our perspective, because in King County, our part of the de-siloing efforts is about this interoperability, integration type of plan. So we're not, how would I say, our goal in our region is connecting the data and the technologies. It is not about having one technology rule them all. It really is about interoperability. So that is really what we are building in the table that we have set through our Connect to Community network.
Yeah, we've got some really archaic things though in statute that we're having to figure out how we break through, like data ownership and privacy and consent. And there's really some significant information authority types of issues here that have to be dealt with. So we'll get there. It's just taken some time.
Were there any other questions for Gina? Okay, well, let's give Kate the floor. Number 2 is creating a center in mental health policy and the law.
See if I can manage to unmute myself and look at my notes at the same time. So at the last summit, Dr. Jennifer Peel actually presented on creating a Center for Mental Health Policy and the Law. Next slide. With the broad initiative was to develop a multidisciplinary university-based center to kind of help prepare the state to make more data-driven decisions customized to local environment, specifically at the intersection of mental health and the law. And the idea was, next slide, to have to develop an interdisciplinary center that worked with various affiliates and partners that would have kind of 3 pillars, one being research and research-driven policy, and then service in the form of consultation and evaluations, and finally education and training, both potentially in the form of workforce development, but also training health professionals. And you know, there are a lot of people in the state already doing some of these things, so this is not meant to replace those efforts, but as a complement and a kind of a central place for the university to kind of be involved. Next slide, please. So current progress. So we were approved by the Office of Research at the university as an official center. And Dr. Peel is the director, myself and Dr. Kopelovich will be other core faculty. And we focused our initial resources on outreach and building connections and partnerships. We did a needs assessment with using an online survey of interested summit attendees, so people who had expressed an interest in this area, and other kind of known community stakeholders, to both provide some outreach, talk a little bit more about what we were doing, what our mission was, and identify some of the areas of greatest needs for service research and training. So far, we have about 71 responses from a variety of stakeholders, including individuals with lived experience, administrators, law enforcement, attorneys, judges, behavioral health and medical care providers, forensic evaluators, researchers, among others. Actually, the other thing is we had kind of an inaugural grand rounds in the psychiatry department today, which Dr. Pila gave, introducing the center. So that was exciting. Next slide, please. So in terms of successes, the things I discussed in the previous slide, the center designation, we've been able to identify some affiliate faculties, and other partners are working on collaborating with other people within both our department, the law school, and in the community. We've also been able to identify some potential clinic space in the health sciences building, at least for initial development of a clinic until other, hopefully, larger spaces open up. Some obstacles that we've encountered so far are, protecting dedicated faculty time to work on further developing the center. Exploring payment models for a forensic clinic within the university system, clinic/consultation service. And the responses that we received in the survey, the needs assessment survey, reflect a really great need for, in the state for mental health services, housing services, all made worse by the pandemic. So there's really kind of I think one of the questions is where to start. So next slide, please. In the short term, we are working to continue our outreach and engagement. We're putting together a newsletter that will have kind of regular updates on our activities that we'll distribute to interested parties. Hopefully that'll come out in the next couple of months, or the first one will come out in the next couple of months. We're also working on a forensic webinar series, which should come out some point in the spring. Kind of other next, longer term next steps are developing initial projects and partnerships, expanding the training opportunities, which the webinar series is a kind of a professional development series, but providing additional training opportunities for residents and other professionals, and kind of going through the steps to setting up the service component in the form of a clinic, working through the various barriers that will just be part of the university system. And kind of other things, we definitely welcome additional suggestions for partnerships and funding resources moving forward. I guess that's my pitch. Any questions?
No questions, but I can add that Dr. Peel's presentation today at Grand Rounds was fantastic. We're working with the advancement team to raise additional funds. We've had some generous donors give money for this already, but we're planning an event in January to move that forward. And the Grand Rounds that she gave today actually resulted in a donation. So yes, so it was very good. Very inspiring.
Yes, it was good. I think it's recorded if anyone wants to look it up later.
Yeah, we'll have it posted probably by Monday or Tuesday.
Great.
Kate, I'm curious, this law center, if you're familiar at all, might this be similar in type to a place like the Saxon Institute at the Gould School of Law at USC?
I don't, so it's interesting, as part of developing this center, we did a survey of a variety of other centers, and I think I'm forgetting her first name, but the center at USC is one we looked at. I don't think we interviewed her specifically, and I don't remember the quality. I don't think that her center has kind of the same breadth of focus in terms of service, service provision in addition to kind of research and education. But I don't quote me on that, because I don't remember the extent of what she provides. But so I think it would be in some ways similar. I think what we're hoping to offer is just a little bit different and potentially a little bit broader. Some of the other models we looked at, places that have similar centers, were at the University of Virginia has a similar center where they've been able to kind of have these similar pillars of service, training, and research and advocacy. There are a few others around. I think some centers have chosen to focus a little bit more on one aspect more than the other. So that's a yes. I'm familiar. I'm vaguely familiar with her center, but I can't give you a full answer without reminding myself more of that.
Cool. Well, thank you, Kate. Let's see here. Jenny, tell us about ending the silence.
Great. Yeah, thank you. I'll just kind of give an introduction. Again, I'm Jenny Gruenberg, NAMI Washington Youth Outreach Coordinator. And the next slide will go into a little bit more detail about our program. So we are working to expand our Ending the Silence program. As some of you may be familiar with the structure of NAMI, we have 19 affiliates throughout Washington that offer support groups, educational programs, and presentations like Ending the Silence to their local communities. And so Ending the Silence is a newer program that NAMI has created to provide mental health educational presentations to middle and high school students, families, and school staff. The presentation is co-led by a lead presenter who goes through a PowerPoint presentation about mental health. It talks about mental health conditions, mental health in general, sort of the warning signs and things to look out for if a young person may be struggling with their mental health. We also discuss positive coping strategies, touch on suicide, and really empower students to be supportive advocates for each other and to reduce the stigma surrounding mental health. And then we have a young person who shares their personal story, and they're between the ages of 18 and 35. And both of our presenters have some form of lived experience. They are either someone who lives with a mental health condition, or they are a family member of a loved one with a mental health condition. So that peer component of our work is really important. And those personal stories make the presentations really engaging for students. So that is what we have been trying to grow throughout the state. And if we go to the next slide, I can share some of the things that we've done so far. And what I guess the thing that we're looking to do is to be able to provide this presentation to all schools that are seeking mental health support for their students, staff, and families in Washington, and to make sure that there's the ability to utilize this as a resource, since it is free and evidence-based. And then our larger goal, of course, is always to try and eliminate that stigma surrounding mental health and illness. Next slide. So far, we're offering consistently presentations in King, Pierce, Thurston, Mason, Skagit, Whatcom, and Yakima counties. 14 of our 19 affiliates have embraced the program, and they're all kind of in various stages of implementing it. So in King County, we have 3 affiliates, NAMI Eastside, NAMI Seattle, and NAMI South King County. And those 3 affiliates have done a lot of work to bolster their programs. NAMI Seattle and NAMI Eastside having really robust programs, and NAMI South King County working to really support and build their program, but they at this point are kind of all volunteer run. So a little bit less capacity there, but we've been able to kind of support them throughout King County as just an example of what it looks like and how our affiliates work. We also, since the summit, have implemented a monthly Ending the Silence work group where we get regular check-ins with our affiliate leaders who are offering ETS in their communities, but also we partner with folks from Crisis Connections and people who are doing suicide prevention work in sort of at the county level and things like that to really bolster and help us expand and think about what we can do to make the program more sustainably implemented in schools. We've also received a grant from Kaiser Permanente through their Thriving Schools program. And as some of you may be familiar with the Ghosted program that Kaiser currently has, where they work with schools, specifically schools that serve students at a rate of 50% or more students utilizing free and reduced lunch. And they go in and give sort of a theatrical performance. Obviously, it's all virtual at this point, where they follow the lives of 4 students and sort of the different mental health things that arise for them, and then have a chance to talk with students about stress, anxiety, depression, things like that. And so they've been finding that they're really seeking that additional support for their school staff and for their families. And so we're working to offer monthly ETS for families and ETS for staff for the schools that they serve, which is really great to be able to expand our reach that way. And then we're also working with Todd and Laura Crooks and Jim Bollendroff, I'm sure as well, on the OSPI Mental Health Resource Library that's being created. And we're hoping to have ETS listed there so that all school districts know that it's a resource that they can utilize for free. Next slide. And then, so some of our successes, in March of 2020, when everything kind of came falling down around COVID, we quickly transitioned to offering all of our presentations online. So we're still able to work with a lot of schools. We didn't have as many requests, obviously, in the spring of last year, because I think schools were really still trying to figure out how to adapt to online learning, but we've seen a huge increase in requests for presentations this fall, which has been wonderful. As I mentioned there. And then some of the obstacles that we're facing is really making sure to identify peers, specifically those between the ages of 18 and 35 who can share their lived experiences. Just because that age range, you know, folks are going to school, their lives are kind of more in flux and not maybe as settled as folks that are a little bit older. And so we're always looking to recruit new volunteers to meet our demand of presentation requests. And then also just reaching new schools. We have kind of established relationships with certain schools that ask us back every year, typically health teachers or folks teaching psychology or things like that will have a unit where they cover mental health, and they'll bring us in every year at a certain time or every quarter even, which is wonderful. But we want to make sure that we're making new connections with schools and letting schools know and just get the word out about this free resource that they can utilize to help support their students, especially through COVID, when mental health challenges in students are rising. Next slide. And then looking towards the future, we want to make sure, again, that we're maintaining a sustainable program. So we're really looking to always train more volunteers so that we can be sure to fulfill the number of requests that are coming in. And then working to secure additional funding to sort of hire youth programming staff at the affiliate level. So I work with all of our affiliates to kind of help coordinate and to train our volunteers. But we want to make sure that we have someone at the affiliate level to be able to really work on that scheduling piece, because that's kind of a big time effort that goes in, making connections with schools, scheduling presentations, keeping on top of that. And you know, this is kind of an ongoing program, so there isn't like a clear completion date for us, but we want to make sure that, you know, all of our affiliates are able to have a fully functional and sustainable ETS program that will eventually look like we're able to, you know, have more paid staff that can help work with presentations in terms of scheduling. So that's kind of what things look like for us. Are there any questions?
I can say that this is a perfect example of an older summit initiative meeting a newer summit initiative and complementing each other, because a couple of years ago, mental health education in schools was a huge initiative that Laura and I led in a summit where we were trying to advance mental health education. And this library is something that just started getting built. Chad's Legacy Project has contracted with the Smart Center at the University of Washington, and this library is now getting built. There's a fledgling website that we're starting to create, and this is a place where ETS will be able to live and outline for schools exactly what's in it and exactly what it does. So it's really exciting, and it's fun to see the two initiatives kind of come together.
Hey, Jenny, this is Jim Bollendorf. I have a question. One of the challenges that you mentioned was recruitment of peers and the young people to participate. What do you do to help mentor them or keep them connected in between sessions? Like what kind of, and actually, I don't even need you to respond as much as I'm thinking there might be an opportunity. I don't know if you've yet connected with Kevin Hale, who's working with Cities Rise, who's developing a youth network. And I'm thinking between Kevin and the work that Josh does with Peer Seattle, if there's not some synergy that could be happening around supporting young people, because with Cities Rise, what they're trying to do is create a youth network where we're helping build leaders out of young people with lived experience. And so I think there might be some synergy that could happen in that particular space.
I was thinking about that too, Jim, about Cities Rise, that's a perfect connection.
Yeah, I think it would be a really nice connection to make. And if you're interested, and Josh, if you're interested, I'd love to sit down and have a meeting with you guys and talk about that.
Good.
Yeah, that would be wonderful. I think we've definitely found that, especially through COVID, we've been more intentional about how we can create community among our presenters. And we've had a couple events, but the more that we can connect them with the broader peer network, and I think the better. So I would love to arrange something.
Great. Jenny, have you and Kevin connected at all? I've given him so many different names. I don't know if he's had an opportunity to connect with you yet.
The two of us haven't directly connected, but I know he's connected with one of my colleagues, and I've just been so busy with ETS that is on my to-do list to get in touch with him, but I'm planning to, absolutely.
Okay, great. Thank you.
Okay, so we've got 4 initiatives left. We're just about an hour in. This is going to go till 5:30, and I want to be respectful for those that are yet to go, in case anybody has to jump off before the next 15-20 minutes are up. Are we okay with the order that we have, or does anybody need to get theirs under wraps real quickly? Okay, so good. Then we'll run through these 4 that are left, and then Laura's going to lead a bit of a discussion on what we can do as a summit to help kind of enhance things going forward. So without further ado, Brenna, go ahead and take it from here.
Todd, this is Melody. I got an email just like 2 minutes ago from Dr. Wren stating that she would not be able to make it. How would you like to?
Well, let's run through her slides.
Okay.
And basically, I don't know, Laura, if you know about this or not, but there's been discussion for quite a while about developing a baccalaureate level behavioral health support specialist that doesn't require extensive schooling for psychology. It's a way to kind of build the workforce in mental health and create some frontline service people, much like certified peer counselors, but
Also that are reimbursable.
That are reimbursable, so that maybe we don't need to fill the void with psychiatrists and psychologists to the extent that we have now. So this work creates a position and a level that might make it easier for people to find a pathway to get these kind of jobs themselves.
If you go to the next slide, it'll probably just.
So the next slide is the description, and we'll just all read through this together.
I love it.
It's not for those critical crisis moments, but low intensity interventions. Jim, can you touch on the step care model idea?
You know, I don't know a whole lot about the step care model. I know about the initiative overall. And again, in the sense that what we're trying to do is make sure that we're tapping into this workforce of people who go and get a bachelor's degree in psychology. I mean, there's a lot of young people who get a psychology degree. And this is modeled after a program that's happening in Europe, where if you provide them the skill set in evidence-based approaches to care, they can actually do a lot of work, allowing people to practice at the top end of their license when they need to. And so this is really just a great workforce initiative.
Cool.
And I know that it was meant to be in that step care model, that it's a partnership around care for any individual, that this isn't the sole person providing care, but it really is team-based care, and a team-based model for efficiency and for effectiveness for that individual.
This is Becky. I can just say one thing. Yeah, so they did a pilot of this program at UW, I think last year or 2 years ago, that was very successful. And so all of the curriculum was built, and I believe then we have now some money to move forward with it and make it an actual degree. And so are working through the logistics of that. That's my understanding.
Okay, let's move to
I can shed a little tiny bit of light around what stepped care is, just because that question was asked. So stepped care is really about this idea of providing enough resource and enough support to someone, but not over providing. It's really about empowering people to get well and to work in their recovery with just enough resource based on what they need, and not disempowering people by doing too much for them.
Right.
Thank you, Allie.
Thank you for that.
Yeah, and one thing just quickly, that we've also talked to Jürgen and to Anna Ratscliffe about the potential for marrying this with our apprenticeship program that we're building out. And we see that they can be just two really complementary things to developing the behavioral health workforce in the state.
Great. I'm glad you said that. I was just thinking that, Jim.
Thank you for advancing, Melody. So they've received stakeholder feedback from a sample job description. There have been 2 cohorts trained in the undergraduate UW program, and there's been a pilot study like Becky mentioned, and they're working on developing core competencies. So it appears to be well underway. Let's go to the next one and see what she's got for successes. Eastern has a pilot course as well. So growing to the rest of the state. Obviously, COVID has been a disruption there too. Staff turnover is always a thing, and it's dependent, Lisa, on the legislature and getting some work done. So maybe you've got some insight there as to what those possibilities might be.
Oh, but I'll definitely be looking to see if it's in the stockpile of budget items. That's for sure.
Cool. Okay, so finally on this one, Melody, let's go back to the last one. Hiring and education, developing clinic partners, and finding a system where this can be embedded, and creating the reimbursement codes so that this can be a paid and reimbursed practice. It looks like she was going to talk about Senate Bill 5053 or others, but I don't have the language for that bill. If anyone has a little bit of understanding what she's got there, you're welcome to chime in.
We can leave that one to Lisa to look up.
Yeah.
I looked it up right now for sure.
It has to
Okay.
do with, this is Melody, it has to do with increasing the behavioral health workforce
Great.
by addressing certification and licensure requirements, and just chiming in a little bit here on the synergy between this work and the behavioral health apprenticeship. It's very, very, very aligned. And when on the previous slide in talking about legislative support, that's more than fiscal support. That has to do with taking a look at how competencies could be better aligned, or using competencies as opposed to arbitrary hour limits on licensure requirements. And then also, if we wanted to get real movement on this, we would need to take a look at credentialing the bachelor level pathway, and like this says, figuring out a way to make that reimbursable, but also aligning that for movement towards higher level degrees. There's a lot of legislative opportunity for support in the rules area as well as the dollar area.
Thank you, Melody. That's really helpful. I can see Lisa taking notes already.
I am. Yeah, I've got it. Yep. Yeah, and I see that. Yeah, so it's all in this bill that didn't make it through last session. So yeah. Okay.
I'm not sure that Q&A on this one is going to be super productive. We can always have you reach out to Dr. Wren if you've got questions, but let's go ahead and move on to improving perinatal behavioral health.
Thank you. And Melody, would it be okay for me to share my slides on my screen? I made a minor last minute change.
Absolutely. Let me stop sharing here.
Thanks.
And I think everyone has permissions to share, so you should be able to move right into
Yes,
it.
I do. Well, and while I'm pulling that up, let me just share how excited I am that we will be meeting in person, hopefully, because it was, for the next summit, it was in lunch lines that I made a lot of good connections last year. So, and this is what we presented at the summit last year, improving perinatal behavioral health in Washington State. And just to briefly kind of frame the challenge, mood and anxiety disorders during pregnancy and in the first year postpartum are very common. They affect up to 1 in 7 pregnant and postpartum birthing people, but only about half of these people are detected. And that relates to, screening practices in organizations. Only 15% receive any treatment, which might be 1 session of psychotherapy or 1 dose of a medication. Only 7% receive enough treatment, and only 4% are treated to remission. So, and we know that maternal and parental mental health is intimately connected to child mental health, and there's intergenerational transmission of risk. And we're focusing a lot on this in our prenatal to 5 relational health subcommittee meetings. And, perinatal behavioral health problems are now the leading cause of maternal mortality in Washington State and in several states in the US. So really a critical public health problem. So what we wanted to do is create a statewide learning collaborative. Given that these parents interface with different clinical organizations and community-based settings, and each of these organizations are at a different place with regard to their screening practices or their referring practices. So we wanted to create a learning collaborative where each participating organization would identify their own target for improvement based on where they're at. For example, an OB practice might want to screen and treat, but a community-based, say a home visiting organization might want to screen and refer. So we wanted each organization to pick a QI project that made sense to them where they were at, and then come together for shared learning over the course of a year and a half, and try to implement best practices for perinatal behavioral health across different organizations in Washington State. And we did get a lot of interest, in the polls and surveys at the summit last year. But of course, organizations are limited in how much time they have to be able to set aside to participate in something like this, because, we have to have time to come together for our shared learning sessions and then go back to your organization and do your QI activities. The ultimate goal of this, and really all of our activities at the Maternal Child Mental Health Center, is that all perinatal people have access to high quality and timely behavioral health care. So, like I said, we did have a lot of interest from the participants, but continue to look for funding for the initiative. And in the meantime, of course, COVID happened. So what we did was we pivoted to be able to continue to do what we wanted to do for training and workforce development, but in a slightly different way. So we focused on the shared learning by launching our second cohort of ECHO, which is a video conference, case conference series. So there is still that shared learning happening, although not necessarily QI projects being required. And we have been able to recruit perinatal providers in a targeted way from rural counties in Washington state. And we've also provided, separate from these ECHO sessions, statewide trainings for OB providers, for family medicine providers, also for residents and other trainees. We also received funding to start our Women's Mental Health Fellowship, again, all in the interest of workforce development. We also focused on clinical care and consultation. So we have our state-funded PAL for Moms consultation line, and we've had really high call volumes over the past months, probably related to the depression, anxiety that we're seeing increasing in the perinatal population, given their unique challenges. We started a new virtual perinatal clinic, again, addressing this increased need we're seeing in this population. And we continue to provide integrated perinatal behavioral health care in several clinics. We're also, funded to do some studies looking at the effectiveness of many of these programs that we have launched and are running. Some of the obstacles, like I mentioned earlier, is the availability of funds to support organizations participating in a learning collaborative, and COVID-related competing priorities of potential participants. So the future risks for some of our programming is keeping our endeavors sustainable through state and philanthropic funding. Budgets are tight thanks to COVID, so we're all hoping to keep our programs going. And the next steps, we want to continue to gauge interest in learning collaborative and workforce development activities, complementary to what we're doing, or enhance what we're doing based on feedback from our participants. And this is really an ongoing effort. This is our team and our funders, and I guess I can take questions.
Dr. Wren, I have a question for you. So, oh wait, sorry, Dr. Bhatt, sorry. I'm looking at the wrong person on the paper and looking at the screen, and
no worries, we jumped across that one, right?
Yeah. So I have a question for you. At Children's Village, we have a very large nurse family partnership group that goes out and sees these new moms who are pregnant and through that first year and a half of life for that child. Has this program connected at all with the nurse family partnership group across the state? Because that seems like that's a critical connection. And I know that our team has seen many new moms who are significantly struggling with mental health issues.
Yes, that's a great question. And we have connected with them. I first connected with them, I think, 4 years ago. I used to do, I started with the King County NFP, and we used to meet regularly and do case consultations, kind of in an informal way. But more recently, we've tried to build awareness of the different programming, and we have our NFP nurses calling the PAL for Moms consultation line. We have patients being referred directly to our virtual telepsychiatry clinic, which, I cannot tell you all of the pain that's come with this pandemic, but telemedicine is such a big silver lining. We're now able to see patients who would never have met a psychiatrist from, really rural parts of the state who would have had to wait for months to get a psychiatric assessment, who wouldn't have gone because of transportation and childcare barriers. So we've seen several NFP clients in our new virtual telepsychiatry clinic.
Great, thank you.
Yeah, I really hope that, payers continue to pay for telemedicine even past the public health emergency. It's been so responsive to needs. Yeah.
I think it offers, I'm going to just jump on my little bandwagon here because this is what I live in a lot these days. And it offers the opportunity to provide patient-centric care, the right amount in the right place at the right time, and not based on what our traditional views of how we provide medicine, but based on what that patient actually needs, whether they need it in person or whether they want to have it via telehealth, and offer some opportunities for cost effectiveness in healthcare and access for those who wouldn't otherwise have it. So it's an equity issue as well.
Mhm.
I'm with you on that one.
There was a mention about continuing to get paid, and I can't think of a better moment to introduce another advisory council person that came in late. Dr. Jim Polo, if you want to unmute yourself and say hello and share with everybody who you represent, we're honored to have you aboard.
Oh, great. Thanks a lot, Todd. I appreciate that very much.
Sorry, put you on the spot, Jim.
Yeah, no big deals. And I do apologize for logging on just a little bit late. I've actually been listening in for good hour now. So I'm Jim Polo. I am actually the executive medical director over at Regents Blue Cross Blue Shield for the state of Oregon, managing healthcare there, as well as the EMD for Cambia Health Solutions for behavioral health. Regents has a number of plans that are nested within the Cambia Health Solutions family in actually 4 different states: Washington, Oregon, Idaho, and Utah. I had obviously met with Todd and Laura, gosh, it's been almost 2 years ago when things were kicking off in Washington, and actually later on last year, or I should say later on after meeting them, but now over a year ago, had invited them down to Oregon, hoping to really kickstart a very similar approach for the state of Oregon that we have ongoing here with our efforts in Washington. And of course, COVID has, ruined all best laid plans. so
But we won't give up on it, Jim.
No. And these are challenges, of course, that have been with us for a long time. So they don't actually need a rapid or an immediate solution per se. I will share with you, Regents as a company, as a health plan, really is serious about our responsibility to be accountable to our members in terms of truthfully addressing all of those mental health needs that folks might have that would fall in line with what any health plan should be doing that really provides parity of healthcare. We really see mental health as being central to well-being when we just look at the health of any individual. We don't see it as a silo and separate force. I will share that doesn't change the fact that we have in Washington, no different than in Oregon, years worth of legislative type approaches that unfortunately have created fractured systems. And I think what all of this is about is how do we kind of use our sense of being part of the community with different stakeholders involved so that we can, chart a path toward a new future to kind of bring mental health out of that, mired, mysterious, but nonetheless stigmatized background. And so I'm just excited to be part of this, and these initiatives that we're hearing about are just all incredible. Thank you,
Jim. Thank you.
Awesome. Thank you.
We've got 10 minutes left, and we want to leave some time to talk a little bit about the summit going forward. So let's bring in Daniel and Josh to talk about peers.
Thanks, everybody. Thanks for sticking with it. Again, I'm Daniel Smith with Community Health Plan of Washington. So we are one of the 5 managed care organizations in the state of Washington serving Medicaid beneficiaries. And Josh, I'm going to leave a good amount of time for Josh to talk, but I just want to, you can slip to the next slide. So our initiative was really, at the time last summit, was really in a very much of a forming stage, and we are starting to get into that norming stage here a little bit. But our goal really was to establish a peer partnership access coalition, so a statewide coalition, a variety of stakeholders. As I mentioned earlier, my excitement is really around collaborating and trying to make sure that we continue to have dialogue around improving access to peer services across the state of Washington. So we had a goal of making sure that we had an advisory committee made up of peer statewide leaders. Josh is one of those leaders. We also had a description of making sure we had 4 focus areas, which was really brought about through consultation and conversations over a 6 to 8 month period of time with various stakeholders. And then, of course, to support those focus areas, we created in the coalition 4 subcommittees. So it's really, the structure is the statewide coalition, and then underneath all of the work is really around those 4 subcommittees. So you can go ahead and move next slide. At the very onset, we tried to design a North Star. So this is really to improve access to peers in Washington. The vision is really to include peers as partners with an individual's care team, with peers fully supporting their role. Individuals across Washington have access to stigma-free, whole person focused peer support. So that's really what we're trying to achieve through this work of coalition. Our progress, the colors do signify. Green is, we're as a coalition feeling very confident that things are on the right track. And then yellow is more of a, I think through the obstacles of building a coalition during a global pandemic has created its own unique set of opportunities and obstacles. But we really feel confident that as we get more focused and more participation, that the focus areas will come into their focus and really start in their norming stages, and then continue to establish those subcommittee deliverables. And I can get into the focus areas being a data and evaluation. So there's a group that's working on doing some scanning of research and understanding data elements, both related to wellness as well as to cost. Training and peer activities. This is a partnership throughout a couple of other health plans in terms of trying to organize peer activities and trainings across the state of Washington at one sort of truth website. Funding for peer services, which is what Josh is going to talk about a little bit more. And then, of course, all of this, as was just alluded to and has been talked about, has a direct relationship with policy. So how do we leverage a variety of different policy shops? And again, we're not trying to solve all these problems. We're trying to bring people together who are already doing a lot of this work together and being part of that movement. So next slide, please. Our successes, we feel like we've established a foundation to build from. I think we've been able to lay out a structure that is supportive of a coalition, and we'll continue to build that. We continue to grow. We continue to have the evolution as any coalition would. I think one of the bigger successes is that we have very aligned managed care organization support and multi-sector involvement. We've been working with agencies and organizations all across Washington, either at the introductory level or at the what next steps and engagement level. Next slide. So future risks, completions. We're looking forward to 2021, where I think we're all looking forward to 2021 to some extent or another. But solidifying our roles and deliverables for the subcommittees as they continue to work in their spaces around what connections they're going to have and how they're going to leverage all of these partnerships. We are always trying to build broader stakeholder participation at both levels, and then develop a deeper partnership with our allied stakeholders statewide. So again, it's just really partnership, coalition building, advancing that North Star. And then the establish partnership to develop a pilot project. I'm going to hand it over to Josh at this point. This is something that I think we're all very excited about at the coalition level to just help facilitate this vision that I think we are trying to accomplish, that would facilitate more access to peer services in a variety of different care settings. So Josh, I don't know if you're still with us. I lost my talk a little bit about the pilot project and the stages of development that it's in and where it's headed.
Yeah, certainly. I could talk to you about this for 3-4 hours, but I won't do that today. I'm going to try and keep it sweet and simple. I'm just drawing from my experience working in insurance and my person with lived experience with behavioral health and accessing services, even coming off the streets. I think the one thing that I'm hoping to get out of this pilot program is to begin to introduce the importance of community-based peer services and to learn how we can be integrating people with lived experience into the service process so that we can begin to impact people's behavioral health treatment in a way that is more comprehensive, person-centered, and compassionate. Quite frankly, I think our system is set up to continually re-traumatize people and to provide short-term, services that are not necessarily indicative of a lifetime challenge that they may be living with. So what we're looking to do in this process is to embed a peer within a primary care physician office in a federally qualified healthcare system, so that those clients who come to see the PCP who may have emerging or may have impactful behavioral health issues going on can work with that peer to not only maybe talk about services to engage with that they're not already, but also to receive that support and to be connected to our external community-based service platforms. Now, we currently do this service with King County Drug Diversion Court. We just launched the same type of service with King County Jail Health Services, and we're beginning to do it with some behavioral health providers. But this is an opportunity to begin to look at some data with managed care organizations to say, does it make sense for us to be looking at community-based peer organizations as a provider of service to managed care members so that they can have a more rounded experience? And what does that look like? We don't have great data around this. We know in the state of Washington, RDA put out a memorandum in 2015 that stated that for every dollar invested in peer support services, saved $7.60 in emergency rooms, hospitals, and jails. And that's a pretty significant amount of money in and of itself. And when we talk about MCOs working with capitated rates around Medicaid, those folks who are high utilizers who are not necessarily getting the trauma-informed care, peer support, holistic engagement that they need for any number of reasons that they may have, this is where the imbalance comes in. So not only are they being traumatized, but the expense is outweighing what the income is, and that in and of itself is not a good model. What we want to look at is if we begin to engage peer connection services for those folks who are, let's say, if we partner with Community Health Plan of Washington. So if we begin to look at those members and see if we begin to integrate peer services and begin to connect them to community-based services, will they begin engaging in behavioral health services that are more traditional and helpful? Will they stop using traumatic inpatient services or dealings with hospitals and jails? And can we measure not only a cost impact from the managed care organization side that says that when we save this much money, it provides enough to fund a service contract in an organization like mine. But then on the same side, on our side, the things that we measure is, are we actually providing a benefit to the individual? And the things that we measure are social determinants of health. So we want to know, are they moving, this could depend on the person, but we look at things like, are they moving from unhoused to housed? Are they moving from financial insecurity to security? Are they moving from isolation to community engagement? And that community piece is I think what is really lacking for our folks. If they don't have that supportive environment, it's a poor opportunity for them to have long-term care. And then we also want to look at, what are their goals in recovery? Now, when you go and you work in behavioral health, there's going to be a treatment plan, and we want to hit a treatment plan, but there's a bigger part of life here. And there's so many different pieces of our life that impact our behavioral health, our relationships, our family, our legal situations, our job, whatever the case may be. Can we have that system of support in the community that will help us to navigate those in their entirety, because they do all impact our mental health and our behavioral health. And then on top of that, can we have opportunities to be supporting one another because of the experience that we have? And I think trying to marry what we see as a very effective model in what we do and to have some integration in the professional health system is important. Now, I know that when I go to a doctor, like most of us, when we go to a doctor or to a therapist, we tend to frame what we want to talk about based on what I'm trying to get sometimes, and what I feel comfortable sharing with you, and what I don't feel comfortable sharing with you. And even more than that, oftentimes it's why I need comfortable talking about myself, because if I haven't said it out loud, I haven't really experienced it. But to be able to sit in the comfort and understanding of another person who gets it, a little bit of relevant self-sharing creates a little bit of ease. You know, and our folks with the motivational interviewing training and the training that we do around relevant self-sharing, this is their opportunity to create that safety net. So this is where I feel safe. So that fight, flight, or freeze thing is not occurring, and now I can talk. And when we can talk and begin to see what opportunities are available, and we can begin to engage in community support, when we can begin to talk about, yeah, okay, I'm ready to go do some therapy. I'm scared to death about it. I get it. Let's go. If you don't like it, I'm still here for you. If you need to find another provider. These are the things that oftentimes keep our folks from receiving services. And so we're hoping to see in this process, not only a cost savings, but a real service engagement from community-based peers, like what we have.
Thank you, Josh.
I'm so sorry. I'm just being mindful of time.
Oh, sorry.
Yeah, we're going to have Sarah come in and make sure that she gets hers underway. Josh, that was incredible stuff, and I think really important for a lot of folks to hear.
Really super important, Josh.
Yeah, thank you. We're going to move now to housing stability for youth. Dr. Walker, are you still with us?
I am here. Yes.
Yeah, thank you for hanging out.
Last. Thanks for having me. I'm actually going to repeat a lot of the things that Joshua was commenting on. So thank you for anticipating those. What we're seeing in our program as well is the power of the supportive lived experience for helping families engage in prevention services that are stabilizing placements for their children in the home. So I think just given the time, Melody, maybe we can break with convention and just skip to the successes. Maybe skip. Here we go. Yeah, current progress. So I'm just going to outline quickly what this project is. It's just going to take me a second, and then you'll be better able to interpret this slide. So this project is essentially an effort to de-silo two systems, multiple systems really. The court system, where we know the most health vulnerable kids in our state often land, and then community services, particularly family-based prevention services, which because of the way that they're funded aren't always, families aren't always aware of these services, and other systems are not always aware of these services. So about 60% of kids who will experience homelessness ran away or were kicked out due to family conflict. And we know that there's a lot going on there. It's not, simply that families are fighting. There's a lot of needs that may need to be addressed. But our model sort of centers in on finding family services that are going to help support family cohesion and address behavioral health needs to ensure that kids aren't further exposed to health risks through homelessness. And we're taking a system lens, so very similar to the ideas around integrated care. And we're working with 4 courts who are adopting universal screening procedures using routine items they already collect. So we can totally avoid the implementation burden of having to train everybody to use a new screening tool. They're sending those referrals to a youth services or family services agency outside of the court. And that agency is then engaging with the families to engage in voluntary services. That's another important thing, because we don't want these services to fall up under a court order, because that presents risk of not complying, violation, and then having potentially more legal consequences. So we have had over about 60 referrals to this program across the 4 courts. We have 2 courts that are just starting up. So this really represents the activities of 2 of our courts. We've had 35 families triaged, and we're seeing a lot of great successes already, anecdotal successes. Our team is still running the research on this. We'll be looking at the perceptions of the court workers and their perceived value of the program, referring to it, the perceived value by families, and then we'll be looking at youth school engagement, family cohesion, housing, and their court outcomes, whether they reoffended. Next slide. Oh, good. We included a success story. So this is a nice one. I don't know that we have much time to go through it. The idea is that a dad and his kid, they were done with each other. The kid was on the street, in and out of homelessness. The navigator played this mediator role, was able to speak to the needs of the father. Again, the value here in peer support and meeting someone where they're at. And then as a result of that, was able to get the kid successfully back in the home. Next slide. So obstacles. So as everybody, there's been COVID related challenges. Courts moved virtually, which actually has some other benefits for youth and families, but in terms of the navigator program, made it a little bit harder for the navigator to get referrals. We're definitely trying to advocate for these sites to maintain funding for these navigator positions. We're seeing the real value of it. In addition to supporting the capacity of counties to maintain a robust continuum of family prevention, intervention, and housing needs. Our service systems around this are incredibly fragmented, inconsistently funded, don't have oversight. County health departments often are not maintaining lists of all their family-based prevention services. This is not anybody's job, and it makes it really difficult to then connect families to these services. And then we're looking at sort of innovative ways to ensure engagement. These are voluntary services, and we're really focusing on prevention. And the trouble with prevention is that people often don't necessarily feel like they have a problem. That's why it's prevention. So we're looking at ways of trying to engage those families in those services to prevent that youth housing instability. I think that's it. Yep. Thank you. Thanks for letting me be here.
And I just say that I love that you included a success story. Like, I'm jumping up and down.
Yeah, I know, so are we.
Hey, Sarah, I'm going to connect with you separately later. I'm on the board for Rod's House here in Yakima, which is serves homeless youth here, but also very interested in stopping. A part of our mission is to stop youth homelessness, and
fantastic.
Certainly a way of that. And there's several lawyers who are also on our board and work in the courts, and I know they'd be really interested in hearing more about that. So I'll connect with you later.
Oh, I would love that. Thank you.
Mm-hmm.
And similarly,
so from here, I know that we were going to have a discussion about the summit, about how we might structure things differently, about the supports that people need. But it is 5:38 on a Friday night after a really long Zoom week for me. And I don't know about you guys, but my eyes are about to go crossed. So I'm going to do this a little bit differently, if you will tolerate that. And that is, I just want to remind everybody that we have the summit date. The next one is October 28th, 2021. You'll all get an invite. But in the next week or two, I'm going to connect with Melody, and the two of us will connect with each of you to find out how we might be able to support initiatives through the summit. I love, Allie, that the bumblebee is continuing here on the chat, where you are sharing the position paper around telemedicine, and that people are asking for that, and you guys are making connections, even in this group who has met each other before. So we'll continue to do that, but really want to say, you know, we have support for you all for the initiatives. We want to make sure that you feel like you're well supported from the summit, and that there was value both in presenting from the summit, but also in moving forward. Because in the next October summit, like Todd said, it's going to be less about panels and more about initiatives. And a part of that is asking each of you to present the initiatives and how that went for you over this last session. Knowing that COVID threw a wrench into everybody, and yet things are really moving forward. So I'll just, if you can think about over the next few weeks, any things that the summit might be able to do, or any changes in how things are presented that might make it more successful, and making sure that you get connected with the right people to move things forward.
And I just want to add my thanks, you know, on behalf of BHI for not only coming today and for sharing your success stories, but also the incredible work that you're doing. Each one of you listed, you know, COVID was one of the things that got in the way, and yet look at how much you were able to get done even in the midst of this, you know, once in a century pandemic. And so what I'm really excited about is what that means for the people of Washington and all of the folks who are benefiting not only from the services that you're providing, but also as we scale and sustain this work, about all the many more people whose lives will be touched by what comes next.
Mm-hmm. Providing hope for the future. That's what this is about, providing hope and action. And clearly that, you know, when we started this and we went to Jim and we went to Jürgen and we said, you know, what do you think about doing this? And we said, we want it to be different and we want it to be about action. And when we talked with Jim Polo about it, and he said, I'm in if it's about action, you know, like, and action is what's happening. And we'll continue to do that in any way we can. And that's what we really want to support you all is in the action to move your initiatives forward.